Okay. Good morning, good afternoon to my fellow colleagues, church leaders, civic leaders, invited guests from across the United States. Thank you for joining me, Rebekah Simon Peter, for the Uncomfortable Conversation series. So for those of you that may not be familiar with me, I am a leadership and spiritual coach. And for more than a decade, I was a pastor in United Methodist churches. For the last 13 years, I've been coaching and consulting, leading trainings across the country, especially creating a culture of renewal. And I also am putting thoughts to paper, Green Church series, the Jew Named Jesus, and most recently, Dream Like Jesus, Deepen Your Faith and Bring the Impossible to Life. So my work is really about energizing church leaders to fulfill their visions and to fulfill the purposes of congregations in communities so that the churches can be change agents. They can be agents of vision and transformation in their communities. And the Uncomfortable Conversation series is born out of the unrest that we have been experiencing in our country, around the globe. The series was designed to really engage spiritual leaders like you in deep listening, heartfelt discussion so that we can expand our emotional intelligence and to generate renewal during these unprecedented times. And it's my hope that this series will be a forum to openly discuss timely, if uncomfortable, topics that are very important to discuss, such as the one that we're going to be discussing today: health inequities of racial and ethnic minorities and underserved populations. So we know African Americans and other people of color have been historically underserved in healthcare settings. And today we're going to discuss how to understand, how to recognize, and how to address health disparities, effective interventions to reduce these disparities in our communities. And because we're church leaders, we're going to be looking at and asking about how can we be partners in this effort as we're transforming systemic racism, as we're dismantling it, as we seek ways to be partners with the larger world in these pressing issues. So I'm very, very fortunate to have as my very special guest today, Dr. Elisio Perez-Stable. He's the director of the National Institute on Minority Health and Health Disparities at the National Institutes of Health, of which there are 27 institutes. Dr. Perez-Stable's research interests have centered on improving the health of racial and ethnic minorities and underserved populations, advancing patient-centered care, improving cross-cultural communication skills among healthcare professionals, and promoting diversity in the biomedical research workforce. Previously, Dr. Perez-Stable was a professor of medicine, chief of the Division of General Internal Medicine, director of the Center for Aging in Diverse Communities at the University of California, San Francisco. So quite a background. And Dr. Perez-Stable, it's really a pleasure to have you here today. Thank you so much for joining us.
My pleasure to be here with you. Thank you.
Very good. Thank you. And where are you today, locationally? Where are you?
I'm in my home in the District of Columbia. My wife is actually working as a primary care doctor today, physically in the clinic. So I'm by myself with my cat, as I mentioned earlier.
Your cat, yes. Okay. Very good. Thanks so much for taking the time. I know you're an extremely busy individual, even from that location in DC. So we're really excited to have you. And I want to start with something basic. So our purpose today, and in this whole series of uncomfortable conversations, is to be willing to be uncomfortable, to talk about stuff, to ask questions that indicates we don't know, to be willing to listen, to be able to learn, to understand how we can be better partners. And there's your cat, to understand how we can be better partners. And I want to start with something really basic. In the Sunday paper, in my local paper, Casper, Wyoming, I came across an article, Racism and Your Health. And it's an article about what it does to your heart and mind. And I thought it was really interesting. It talked about the chronic stresses on a body of a person that's experiencing directly or even indirectly racism. So could you start by talking to us about what happens in a person's body when they're exposed repeatedly to racism?
Right. Well, that's a great leadway to start taking a step back for a moment and saying that just talking about race is uncomfortable.
Yeah,
Most
right.
people don't find that sort of a casual conversation, get to know someone. Oh, what's it like to be white? Or what's it like to be this? I mean, it's sort of a social upbringing that we have, that we try to not emphasize differences and avoid saying, well, that really influences you. Many of us grew up in our childhoods with not very diverse population around us, and this sort of lays a foundation for some biases that are often unconscious, or usually unconscious. And as we grow up, these become part of our adult life. And acknowledging that and recognizing this discomfort when you encounter people that you've never been around with as an adult is the first step in beginning to address this. But to get to answer your question, so the idea that, first of all, that racism is important in health is one that has taken a long way to be accepted by mainstream scientists, I would say. And still, there's probably a large number of scientists who don't really believe that there is a connection. So I'll start with that. Social scientists have been measuring the construct of discrimination, asking individual people, did you feel discriminated in this or did you feel discriminated in that? And documenting for probably, I would say, 40 years in a scientifically sound, systematic way, how discrimination and racism can impact an individual's health. The most robust data are with African Americans compared to whites, but there are data for other groups as well. And these often affect things like mental health, substance use, some of the behavioral aspects of health behavior or risk behaviors that are bad for your health, whether it be overeating or smoking and drinking, et cetera. And there is a long literature on that. These are all in the social, psychological sphere of science. As we have expanded our tools in biology and since the Human Genome Project in 2000 with genetics, scientists working in multiple disciplines have begun to say, well, what happens when people are feeling discriminated against? Are there physiological changes that happen? And in the late 90s, led by some pioneering scientists, they created the idea of something called allostatic load, which is easiest way to frame it is to say it's a chronic stress burden. Mm-hmm. How do you measure this physiologically? It's a set of measures that we all have used, whether they be related to inflammation or cardiovascular reaction like blood pressure and cholesterol, or things in the pathway of the hypothalamic pituitary adrenal axis, which for decades has been known to, it's the fight or flight response. It's sort of the way that we were programmed, if you wish, to defend ourselves acutely. So if you were a human being facing a danger, a large animal coming at you, you had this response that was evolutionarily anyway, life-preserving, right? But no one ever considered the idea that this would be a chronic issue. And chronically, this kind of response is clearly bad for the individuals. It leads to more diabetes or more heart disease, probably other outcomes like cancer are related, or mental health issues. Or some have postulated that to cope with that, some people overeat or use substances and don't do a healthy coping. A healthy coping would be meditation, prayer, physical activity, pleasant activities that are not harmful. So understanding those mechanisms became possible, I would say about a little over 20 years ago, as scientists began to formulate these theories, these ideas of allostatic load, a chronic burden of stress, weathering hypothesis, which is that you get weathered down over time, and things that happen to you at age 3 in terms of adverse conditions or adverse life events were impacting your health 20, 30, 40 years later. It's very hard to study that with population studies. So one depends on either mechanistic studies or other ways to try to get at this. And that's where I think now there's a consensus that this concept of chronic stress captures what we have called exposure to discrimination or racism. At NIMHD, we embrace the idea that all underserved populations that we study, which include all the race, ethnic minorities, poor people of any color, very rural residents, particularly who are poor and or race, ethnic minorities, and most recently, sexual gender minorities, experience more chronic stress, and that is a common theme related to discrimination or racism that we believe ties some of these things up. Doesn't explain everything. There are some things that are clearly caused by something else, but just to accept that that is a possible mechanism that contributes to health outcomes that we all care about, leading causes of death or morbidity, I think is a long step in the right direction. Now,
if I could say, when I read that article in the newspaper, it was like a light bulb went on. Like, it had not occurred to me, just to tell the truth here, it had not occurred to me to think about just long-term stress. But when I thought about it, and I'm born and raised Jewish, and I know what it feels to be worried about, is somebody going to say something? Am I going to be under attack? Am I noticeable? Do they know I'm Jewish? What's going to happen here? I don't think that my experience as a Jewish person is the same as the experience of a person who's African American, who's clearly, skin color, tone is different, because there's just such a difference that way. So light bulb moment, like, oh, and I got to thinking, so here's what I want you to tell me. The body is stressed, and then there's systemic stresses, right? That's where the health inequities come in. It builds on that physical individual experience. Talk to us about what are the structures in place here that lead to health inequities?
Right. No, that's where I was going next. So it's a perfect question. That has been a harder concept for us to get our heads around. Even 20 years ago, I was thinking and bringing this up, I saying, is this a research construct, or are we talking about a systems construct? So is this something for an organization to address, as opposed to can we formulate this in science? I actually initially thought about this on the good side in terms of what we call cultural humility or cultural competence. How can we capture that as a research construct? We've come a long ways. We have much better data science tools now to be able to look at big data. And in brief, this structural or systemic racism, which has come very much to light in the last 3 months after the events of the social unrest in the US, relate to our history, relate to our culture, and relate to a legal system and educational and economic opportunity system that has persisted, really only modified slightly over the 400 years of this country's existence. And if we go back another 100, all of the Americas, Latin America included. Of course, we don't have slavery anymore. That's the most grotesque example of that. We're not going out trying to displace and kill the native peoples anymore, as happened for at least 300 years. But that historical trauma that these populations experience do have an impact, and it doesn't get resolved with 150 years of no slavery, or even 50 years of, or less than that, of no systemic segregation. Legal segregation has existed in this country until the mid-1960s. Those legacies of what happened with residential segregation, with redlining, with schools becoming bad in the neighborhoods where African Americans and Latinos and other poor people live, with economic opportunity moving to certain areas and not being available to certain individuals. So it's not that certain population is not motivated, or they didn't go to school, or they're lazy, which has been sort of the stereotype that has been used to justify the structural inequities, but that we have had these structural inequities that have had this sort of a subversive effect on our society, and that people have felt has been the norm. And then facing that is uncomfortable because it will take work to make that change. And it starts by acknowledging that, yeah, this has happened, this has been there, and now we've got to start talking about it and seeing how we can begin to change it. There was a very powerful short essay that a Johns Hopkins scientist who's now chair of their Department of Pharmacology wrote, where she expressed how during her career as a scientist, and her lab studies something related to metabolism of drugs in the liver, so it has nothing to do with these topics, would get comments about, if you experienced a racist experience, what did you do to provoke that? Sort of like blame the victim, or, oh, it can't be that bad, and change the subject. So that in reality, she's a successful scientist, highly recognized in the field and in her institution, and yet she experienced these same things. She was able to say, she would complain about it, and people would kind of like say, okay, they looked the other way, or they said it can't be that bad, or what did you do to make it happen that way? And there are some parallels with the issues around sexual harassment and the Me Too movement, and I think that some of the ability to be able to talk about all this, we probably do owe to what's happened in society in this country in the last 5 years around that. So
Yeah.
I'll pause there.
You know, thank you so much. I'm sure I was just thinking about some of our clergy of color experiencing the same thing. Very accomplished people who've worked very hard, been gifted by God to be in the positions they're in, experiencing racism, women experiencing sexism. Well, what did you do to bring it on? And so I'd like to take a moment now and ask our participants, if you've got a question, if you'd like to put that in the chat window. And thank you so much for the introductions that are coming through. I appreciate everybody being here. If you have a question for Dr. Elisio Perez-Stable, you can put that in the chat window, because we're going to be turning our attention to you shortly and making sure that your questions get answered. But let me ask you a question, Doctor. So I know that you're a big proponent of patient-clinician partnerships, and with you know, doctors and patients, people coming together. Tell us a little bit about that, and then what do you see as the role potentially of pastors and of churches? How can we be partners in these important partnerships?
Thank you again for important questions. So I'm a general internist by background, and so I practiced medicine for 37 years. And the power, I think, and really the privilege of having been a primary care physician for maybe no more than 200 people at one time over my career is something I have cherished. I think that there is this concept of therapeutic relationship, that sometimes we see patients who have 5 chronic diseases, they have 10 complaints, and you could easily say, well, I can't really help you. I don't really know what's going on, or I don't know. I know how to do 1 or 2 things to help you, but I can't deal with everything. And yet, listening is so powerful. Reassurance is powerful. Sympathy and empathy is so powerful in that context. Experience taught me that, but we now know better. We know that can be studied scientifically. We know that primary care leads to better health care and better health, and maybe decrease mortality as well. So I'm a big proponent of that, what I call the therapeutic relationship. It's sustainable over time. So it's not that one-time visit, but it's sort of the go-to, manage, coordinate, but also listen to. Now, you asked about partnerships with faith-based organizations, with religious organizations, pastors. And in my research as a community, I'll mention 2 anecdotes. In my research as a community-based or engaged researcher, frequently we go to faith-based organizations. It's sort of like a go-to group. It's not the only group, but community-based organizations, well, churches, ministers, priests, in our community in San Francisco, that was not uncommon. And we had more than one or two or three investigators who wanted to flu shot, promote physical activity, promote healthier diets, promote cancer screenings, set up programs in partnership. We found maybe, I don't know, 80, 90% of the churches we approached were receptive and open to collaboration, to allowing individuals to speak or to have set up activities during after services. And the response was often fantastic. So it isn't, I say it's not the only one because there are some non-community engaged scientists who think that's the only way to get to the Black community, for example. And it isn't. It's an important one, but it's not the only way. And the same would be for the Latino, Hispanic community. And for that matter, I know less about that vehicle through Asian community, but I'm sure that there are other ways through Buddhist temples or other denominations where this would work. In the American Indian community, it's often talked about the traditional healers and the elder in the tribes and how important they are in being able to get health promotion or talk about participating in a study. And I think the scientists have learned that the hard way sometimes, that you can't get to an American Indian community unless you go through a vehicle of how do you blend this or bring this in with traditional beliefs in that population. And then as an individual doctor, I'll have to share with you that a long time ago, I remember one of my patients passed away, which happened not infrequently, of course. This is at home, so I was in primary care, not in the hospital. And I went to the patient's home to be with the family, comfort them, basically, I guess at that time we would sort of make sure that things were appropriately correct in terms of him passing away. And lo and behold, who I found in the home was a priest. And we were both with the family, both with the deceased, and I realized in that moment, like we were both there because we both loved our jobs. We both kind of were doing something different that day, and it was a real connection about a common overlap is this humanity of what we do. So there's this overlap of social justice, which I think all of you have, that I hope all scientists have, certainly all primary care doctors should have as well. And yet that overlap there in that moment was very clear to me and it had a very positive impact on my thinking about these things.
That's neat. So you named two things, social justice on the one hand and the therapeutic relationship. And I think that's really the nexus where a lot of church leaders find themselves and where America, finds itself right now. And so the pandemic has revealed and exposed the way racism fuels health and healthcare disparities among people of color and other minorities. Do you have anything to say about that? I mean, are you feeling more hopeful, less hopeful, now that it's sort of out in the open in this really big, unmistakable way?
Right.
What are next steps for us as a country?
Yes, the pandemic, first of all, although predictable, because there were many, besides Hollywood, there were many scientists who said, this could happen. And sure enough, it did. It took many of us sort of off guard. I would not have expected this disproportionate burden affecting minorities the way it has. And based on the prior knowledge about, let's say, the flu pandemics or the influenza epidemics every year, there might be slightly increased mortality among African Americans and Latinos, but not at this level. And so this coronavirus has really put sort of the finger on the wound, so to speak, of society. Added to that, because it combines not only more morbidity, higher diabetes, more heart disease, but also then the crowded conditions or the kinds of jobs where they can't be working from home and stay safe. They have to go out and do deliveries or work at the grocery store or work in construction if they have a job, which is another big if. So a lot of people were laid off. I read earlier today that within the first month of the pandemic, sort of towards the end of March, 40% of people who were earning under $40,000 a year as a household were unemployed, who had a job. So that they were disproportionately furloughed, laid off, because they were in that business sector that really shut down, as opposed to professionals or others who were able to do their work from home. However, the killing of George Floyd was a trigger for this other chronic pandemic of revealing the level of racism in our society. And it wasn't, again, individual, one person, that police officer who did what he did, or the others who have done other things, because he wasn't, Mr. Floyd was not the only victim in this episode, in this saga. But it really revealed sort of this structural problem that we have. And I think that's been an aha moment for society, or at least for many in society. I can guarantee you it has been one for NIH and NIH leadership. Although I read statements made after that event where, racism in health, or, the injustices, that I kind of saw with a little bit of cynicism, to be honest, because I said, well, you never talked about this when I knew you for 20 years. But, I was still glad that leaders of that type were coming out and making that statement. And hopefully those institutions are going through the same kind of process that we're going through at NIH, where we're really very, very systematically thinking and reflecting on this and how it has impacted us, not only in our science and what we do research-wise, but also internally in our own institution, and how we may be part of the problem of perpetuating some of these institutional practices that have created these structural racists in the scientific world, perhaps. But clearly those are. Now, how do you deal with that? It's a big question. I don't have the answer, but I think if we start talking about some of these issues, you can come up quickly with 5 or 6 things that could make a difference in communities. And in a science perspective, NIH could do studies that show that if we take a community that has not been healthy and do the things we know work, so not new things, but do the things we know work, get people physically active, create a safe environment, access to healthy foods that's affordable, have broadband internet for everyone that is affordable, like electricity would be, and make sure that the environmental issues of cleanliness and rodents and et cetera are addressed. Will that make a difference in how many people develop diabetes or have substance abuse or interpersonal violence or heart disease and all the other things that we know are related to these structural factors? And I think we're at a moment where if we decide to make that kind of investment, we as scientists could conduct those kind of studies to show that this is worth it for society to invest in these things, because ultimately we'll save money. If we'll have more resources to do other things. And that's one of the things that people keep forgetting. We're in a capitalist society. We're supposed to, but it is about resources. And if we have 50% of the population not healthy or not contributing, then that's going to cost resources to the society. And if they were contributing, other ways, it would help everything be better, I think. So sorry.
Yeah, especially, no. Especially, I'm just jumping in. Especially as we approach a plurality, of ethnicities. We have a plurality rather than majority and minority. Right. In terms of our population, I think we're approaching a new normal in terms of our ethnic makeup as a society, which I think is very interesting. And that your research would really, there's going to be more call for it. There's going to be more pull for it. So just to sum up, would you say you're more hopeful?
Oh, right. Yes. Yes, I am more hopeful. I'm an optimist, if you can't tell,
Yeah.
by nature. So despite the adversity of this pandemic, which we still don't have an answer, a clear answer or a clear way out, we have ideas and hope that, but it's going to take a lot of work. But I am more hopeful that this crisis has really brought us together to really address these fundamental issues in the
Yeah.
US and globally,
Yeah.
because this is not just a United States problem. This is not a US issue only. Exists everywhere in the world.
Well, and police violence, or, you know, those sort of sanctioned kinds of violences that are there, that's a public health issue,
That's right.
right? Like gun violence is a public health issue, but it hasn't been approached in that way. Do you have any hope that that might sort of evolve, that we could look at public health issues less politically and more in terms of incidence, you know,
Right. Well,
the
in my
prevalence of these things?
in my scientific background, that's always been the case. But yes, you're right. There are some topics that become politically unacceptable for a variety of reasons. We have kind of returned to looking at interpersonal violence, including firearm violence, as a public health science issue, and Congress has allocated resources specifically for that.
Oh, really?
We have not shied away from that research. It's research, not, you know, as long as it's not advocacy, but that would be true for everything NIH does for at least the last 5-6 years. I think there are, you know, in the police violence issue, we actually funded a research grant by an investigator last year on this topic. I don't think they have results yet, but it is that would be more uncommon. But you know, if it gets reviewed and gets well scored and it passes all the mustard, why not? We should fund it. Yeah.
That's great. Well, that's really great. I'd like to see what sort of questions are percolating for the folks that have been listening. What sort of uncomfortable truths may they be coming to, or uncomfortable questions they may want to surface?
Absolutely.
We've had one so far. Yeah, and thank you so much for your generosity of time. And who knows what folks will ask, but let's see. So I want to encourage folks, if you have any sort of question, it doesn't matter how small or big, that you'd like to ask Dr. Perez-Stable, please put it in the chat window. We've got one so far asking about the major cause of illness because of race. Is it stress, or are there other major causes of illness for people who are, let's say, ethnic minorities at this point?
The starting point for us is to see when are there differences by race and race and ethnicity. The classic paradigm in public health science had been, well, it's all about social class or socioeconomic status. So poor people almost always do worse than people who are middle class, who, et cetera. And there's some sort of a threshold or a linear effect that flattens after a certain level. For example, college degree is, you see a lot of flattening in behaviors and outcomes after that. Or in income, an income of over $100,000 for a household of 4 seems to be a flattering curve. Within that structure, though, there are race ethnic differences that are unexplained. I'll give you the example of maternal mortality. African-American women have 3 to 4 times the risk of dying from childbirth than white women. And that seems to be independent of their social economic status, because Serena Williams almost died. And I'm sure she had the best care possible that anyone could get. And so that's one easy example to remember in this case. So what does racism cause is a hard sort of linear response. It's sort of, if you get this cumulative chronic stress, then it's associated, the strongest associations are with behavioral issues around substance use, the triggering mental health problems, depression, overeating, and violence. Those are clearly the ones that have the best data. But we consider that there's probably a factor related to other things, such as cardiovascular disease, which has very much a component of sudden death or precipitating clots in arteries, and related to stress, potentially cancer. That the cells are not as good as cleaning up those, we're always forming cancer cells all the time. That's just the normal body is. And we have these great cells that clean them up and get rid of them. Does that mechanism get altered by chronic stress? And it's not, I don't think it's feasible, although people will try to reproduce this in an animal model, let's say, to try and see, well, how can we get this to work? Because we're talking about literally years, if not decades, of cumulative effect over time. And a 3-year-old, you're not thinking when they're gonna get sick at age 40 or 50, but that's the kind of associations that we're looking at. So.
Well, really long-term, in-depth kinds of studies. And Doctor, we've got another question about thoughts on the impact of food deserts in minority communities on chronic health issues.
Right. Now, this has been one area that has been studied in terms of the topic of structural discrimination or racism, because the nutrition scientists said, well, there was a study done in New York City a long time, about 20 years ago, by a colleague who said, a patient of mine with diabetes, we tell them to go out and buy healthy food, and here are 5 kinds. And then they went out and looked at the stores around someone's neighborhood, and this is, I guess, Upper West Side in Washington Heights, or compared to Upper East Side, which is, I think, very a much wealthier neighborhood. And the number of stores that had the whole wheat bread, or the 2% milk, or the low fat this, or the things that the doctors were recommending were much, much lower in the poor neighborhood than in the wealthy neighborhood. And of course, New York City, no one's really driving, but let's say that you were able to, you just didn't have an automobile to go somewhere else to get it. So the access is important. The other is cost. I'm amazed when I go to the supermarket, and as I go to check out, if I don't go to the self-checkout, there's a wall of junk food waiting to be purchased as you leave, and it's inexpensive. But go to the farmer's market, which is once a week, and yes, it's a little bit costlier, but there are ways to facilitate people buying it. And one of the things is to use the SNAP vouchers in that context. So in a big city, food deserts exist, which is pretty amazing. Doesn't happen in this neighborhood where I'm in, but in the San Francisco, which is a very relatively wealthy city, the Bayview Hunters Point neighborhood, at least at last time I checked, did not have a full service supermarket. And of course, it is the neighborhood where there's the largest proportion of African Americans, as well as now Latinos and Southeast Asians live. There are a lot of bars or liquor stores, but there is no full service supermarket. And I mean, this is embarrassing that we haven't been able to establish these are, people talk about food deserts and food swamps. So the swamp is where the only kind of food you can get is calorically dense, often tastes good enough that people buy it, and it's inexpensive. So that's the other side of the problem.
It's interesting. I hadn't heard about food swamps, but yeah, I know what you're talking about. Most gas stations, right there is a swamp.
That's right. Yeah. At the convenience store.
Yeah, absolutely. So we've got another question now about chronic stress. How does that affect the educational outcomes for kids?
Yes. The challenge with education in children is this structural disparity in the quality of schools. So if your only option is a public school, let's say, and your public school is in a poor neighborhood, and what funds schools is property taxes, that's one of the fundamental mechanisms by which poor people of any race, ethnicity, but particularly urban living African Americans and Latinos were affected by the policies of redlining and residential segregation, the leaving the inner city to go to the suburbs, a trend that has reversed for different reasons, but that led to a whole generation of children going to really inadequate schools. It wasn't a lack of teacher motivation. Even if their pay was less, there were plenty of, but it was just too big a classroom, not enough support, and coming often from, unfortunately, problem families or homes. I was, my older son was in a public high school, a school of the arts, and I was on their sort of board or their advisory group as a parent. And one of the remarkable things that school was able to do was, accept its kids from all of San Francisco and actually outside the Bay Area, was that they were able to bring all of the underprivileged kids who had lunch at school, the free lunch school families, their scores in humanities and language, which were the ones that the departments that had done this remarkably. In 5 years, had erased any differences with the children like my son, who would come from more middle class, upper middle class backgrounds. And that was remarkable. And I said, you guys have really done a great job with this. This is not something that most places do. And they were just like, oh, we're just doing our job, But I think the educational emphasis early is what's important. I mean, people will say that it's in the preschool era that you need to start with this, stimulating children, making sure they move along the learning. They arrive in kindergarten and already have a challenge to be able to learn because of a variety of factors. They fall behind and fall behind and fall behind. And that's just a never-ending, rabbit hole that people fall into, so.
Yeah, and there's another question here about how do we encourage health food stores? How do we encourage health food stores to move into these neighborhoods? What additional action steps can a community take? What can a church do?
Well, I'm not as familiar with what a church could do, but I'm sure that there are many things that could happen. I think that one of the policy issues is about how we price certain foods and allowing market to govern everything. Food subsidies work. Food assistance or SNAP vouchers do work. Like if someone is getting food assistance, they're able to use them in a farmer's market or in a certain store, then they get motivated to do that. You can still buy lots of food because in bulk, but and then have a way to make sure it doesn't spoil, which is a problem sometimes, with healthier foods is more likely to spoil sooner versus packaged, processed, and preserved food, which is easier to preserve. And if you're going to buy processed food or preserved food, then there's healthier options there. One investigator in Oklahoma, American Indian, got convenience stores to change the way they presented their food. So the fresh fruits and vegetables that they had, rather than in the back corner of the store, were moved to the front, close to the register, and very nicely laid out, visible to the client and customer. So as opposed to everything in the front being the high caloric dense, and that actually worked to get the native people in that community to buy more healthy food. So I think there are things both small and big that we could do, although it does take some level of political will and working across sectors. So you're right, the faith-based organizations can help, but we also have to work with with the zoning offices in cities. We have to work with transportation. We have to work with other community-based organizations as well as business owners to make real change in a community.
Yeah, thank you so much. It strikes me that we have a wealth of knowledge among our audience here today. People who serve in wide variety of places and situations. I'd like to hear from our audience in the chat window. What are you doing in your particular setting? What are you doing to address health disparities, systemic racism? What sorts of things are you taking on? And let's see what sort of wisdom emerges from us as well. feeding ministry that bans certain food donations to increase the nutritional value of food boxes, white bread, Vienna sausages. Yeah, I'm often surprised by the kind of food that's requested for feeding programs, backpacks for kids over the weekend. A
Mhm.
lot of it strikes me as kind of junk. I mean, I know it might be easy to eat and easy to get, but I think there's something we could do about the kinds of foods, because churches are great. We're great with food. You know, we really want to see people fed. We care about that. And it's fairly easy to do. So that's a great idea if we just even increase the quality and the kind of food that we're asking for, and we ban other kinds of foods, or we say, no, we're not taking that. I've worked at the local food bank. I'm also a master gardener, and so
Mm.
I help out at our weekly farmers markets. And boy, our farmers market's way out of the way. It's not near, it's near the where the rodeo happens, but it's not necessarily near where I'm in Casper, Wyoming. It's not necessarily near where maybe lower income folks live. So one backpack program only asks for monetary donation and has a nutritionist order the healthier packaged options. So yeah, very interesting how we can raise the standard ourselves and not just think we have to ask for peanut butter and macaroni and cheese. You know, that there
That's
are
right.
other options.
That's right.
Mhm.
And nutrition is definitely one important thing. The other is getting people to do more physical activity. Um,
Mm.
from a science perspective, it's been impressive how almost every study ever done on physical activity, and we're not talking about, you know, working out for an hour at a heart rate of 150. I'm talking about just walking and doing a certain amount of physical activity helps everything. It helps not only live longer and feel better, less depression, better cognitive health, better heart health, less cancer. I mean, it's just really amazing. The only thing it could be bad for are your joints, depending on what kind of activity you do. And of course, if you're not stable in your walking, there's potential risk of falling, particularly as one gets older. But that is something that we don't systematically do enough. You know, I realize that not everyone can go upstairs in a building for a variety of reasons, but there's no reason why most of us can't walk up to the second or third floor in a building and do some physical activity through your routine. When we used to go to a physical place to work, now, of course, people have to get used to walking around their neighborhood. And yes, it's uncomfortable now in Washington to go out for a walk at 90 degrees and 90% humidity, but got to find the time and place to do those kinds of things, because I think that's another important activity we have not promoted enough.
So that's good. You brought us back around to the key word here, which is uncomfortable. You were talking about, you know, being outside in 90-degree heat with a certain amount of humidity, but the purpose of our conversations is to get uncomfortable and to ask questions that may make us uncomfortable, to hear answers that may make us uncomfortable. So I'm going to put it back out to our participants. What are you uncomfortable learning or hearing about today? You know, where is your discomfort? Or what are you not asking because it might be uncomfortable to know the answer? And then I'm going to ask you, Dr. Perez-Stable, where do you want us to get uncomfortable? This is important for us. Where do you want us to get uncomfortable? What do you want us to be uncomfortable about so that we would be willing to make a change, so that we can partner in some new ways for our society?
Do you want to wait for other people? Or you want me to say?
Well, I really do want our participants to get uncomfortable or fess up to what they are uncomfortable about. Okay, we've
Well,
got,
we started with race, and I
yeah.
think that's a major one because, like I said at the beginning, it's not a topic that we are brought up to talk about, and because we feel uncomfortable thinking about it. We feel uncomfortable that anyone would think that, oh, you might have a bias, but you know, everyone has biases, and that's a given. Discomfort happens. And if we don't begin to talk about it and discuss, or how might this influence what we're observing, both in outcomes or behavior, we will never get beyond where we are now. And part of it is not to personalize it, So it's not like I'm talking about race and you're part of that other group and therefore you're responsible for mine. No, that's really not the way to think about this or go about it. There are obviously blatant actions that do call for some sort of calling out, but I'm referring to being able to discuss this. When this whole episode with George Floyd happened and we started to have discussions about this, I heard from some of my peers, some of my colleagues, senior staff, that, oh, it's really not the kind of thing we do. We don't really talk about race and racism because we just taught that way. Professionally, we just don't. And this is coming from African American or white staff who are very accomplished and leaders at NIH. So I think we have to get over that. And yeah, it's uncomfortable, but we got to discuss it and being humble and acknowledging that, yeah, you can have these biases, and the first step is to acknowledge them, and then you manage them after that.
So acknowledging is the first step.
I think so, yeah.
I have biases, yeah. And I like the distinction that you're making. We had a conversation a month ago in which we spoke with a constitutional law professor, civil rights attorney, Dr. Gloria Brown Marshall, and she was talking with us about the difference between bias, just like you said, everybody's got it, and racism, the ism of it all, the systemic nature of it, and that the two can go together and that they don't always go together. So I think there's something manageable about looking at the systemic nature of things. Mm-hmm. And even so, not to the point where we can distance ourselves from it. Well, I'm comfortable with it. It's out there, but really, what's my part in it? And I appreciate what people are putting in the chat window. So the truth that women will often feed their kids before they themselves eat, creating an additional level of disparity. This is an uncomfortable truth because of necessity and the limited access to food that they have. It's uncomfortable to know that 50% of society is unhealthy, and very uncomfortable to know that options at this time are limited in minority neighborhoods. The lack of access to healthy goods. The church can provide education in this area. Yeah. I'm going to give you the last couple of words here as we're ending today's uncomfortable conversations, but I do want to say that I'm really grateful that we've had this chance. You've been very easy to talk to, which I really appreciate. And thank you for making yourself available. I'm sure that even though you are there at home, you're in conversation with people around the country and around the globe and working at the forefront. I know that the institute that you're the director of is celebrating its 10th year.
Yes.
And that you were telling me that it came about because of the Affordable Care Act was one of the factors that came together for the institute to be established.
Correct.
What's the future of your particular institute and minority health? And then I want to ask you to leave us with one challenge that's going to make us uncomfortable.
Okay.
Okay.
Well, the formation of the center in the year 2000 was really probably the most important landmark point, because it went from being an office in the NIH director's position to elevated to a center where now it was able to create a program. And moving to an institute is partly related to a higher prestige, more flexibility in what we could do in terms of funding, and creating also an intramural program within NIH to do our own research, our own science. Having the institute mission recognized as really legitimate science. Okay, so beginning, people would say, it's just politics. Oh, it's social, good stuff, but it's social. It's not science. And being able to bring all of these lines of thinking together and say, well, there is a science to this, because people have different health based on their race or socioeconomic status. And here's the evidence, and perhaps it's going through this mechanism that has been discovered over here, or the microbiome, or epigenetics, or pharmacogenomics. That, I think, has opened a lot of eyes, and all of my peers, I see this, okay, yeah, you're part of it's all part of science, and we're in this together. And how do we collaborate? How do we leverage each other to move forward? So to me, that's the most satisfying part of now 5 years. I've been director of NIMHD and working with a terrific group of dedicated, passionate people at NIH, which is just a remarkable place, and it's one of the real jewels that the U.S. federal government has created over this last 50 years. One word I would say for my colleagues in faith-based churches, pastor, minister, priest world, and rabbis, is that we're partners, and we have a lot of overlap on our goals. There are probably, 90% of the time we're doing our separate things, working in our own spheres, but there is a place to bring people together around advancing certain topics. We're facing now this global crisis, the coronavirus, COVID-19 pandemic. We don't have an answer yet. It's over 155,000 Americans have died. 5 million have been infected. It's not over, and it's not going to be over even after we get a vaccine. It's going to be managed better, I hope. That's our goal. So we need our people to participate in the studies, to be able to show that if this vaccine works, that the participants were diverse, and if this therapy, the monoclonal antibodies or this other antiviral therapy works, that we really can show, well, this was a wide group of people of different kinds, men, women, different ages, different race, ethnic groups, across the country, not just in 1 or 2 or 3 areas of the country. And I think all of you can help with that message to your constituents, to your communities. So thank you for listening and for your questions. They were great, and thank you.
Thank you. So, Doctor, you're saying you want us to roll up our sleeves and expose our upper arms for a vaccine test. Is that what you're saying?
I'm saying, if you so feel inclined to volunteer, as a participant, if you're close to a recruitment site, I think that's a possibility. But actually, as important or even more important is to magnify a message of dealing with the terrible misinformation that has been promulgated out there. The virus was fabricated, or came out of a certain place, and don't trust the vaccine, or don't trust science. There's a tremendous mistrust of science. There's a tremendous mistrust of government. Some of it may be for good reason, but we do need to make progress here. From our perspective at NIH, this is a science response of how we can manage this, but we can't do it alone. And we just need all of the community to pull in this direction and send a message about the trust that we need to regain. Now, I know it's not the majority of people probably aren't mistrustful. I don't think it's much more than 20, 30%, but it's enough to create hesitancy and doubt and conspiracy theories, et cetera, that get promulgated, especially now with the social media vehicle that is so easy to disseminate misinformation. And there are different points of view that are legitimate, and I'm not against that. But yes, promoting participation in studies, if it's available to your communities, and then hopefully when we have one, then promoting people take it.
Exactly. And you, at the very last moment, let's get to a very uncomfortable topic. But yes, from the highest office in the land, anti-science, confusion, chaos being sown. So thank you for speaking to us on behalf of science. And as a government officials, thank you for speaking to us about what's happening, what we can do, the kind of people that we can be, the kind of partnerships that we can have. Thank you so much for being with us, all of our participants. I appreciate each and every one of you and the messages that you will carry back to your congregations, your denominations, etc. And we will be meeting again in a month. We're going to be talking about food deserts and probably food swamps. After that, we're going to be talking about voting and redistricting. And then after the election, we're going to be talking about what's next and how do we move America forward. So continue to join me in these uncomfortable conversations. And I look forward to seeing you the next time. Thank you so
Thank you,
much.
Reverend. Thank you.
All right. Take care. Thank you.
Take care.
Bye, everyone.
Bye.